Hi, everyone. Thanks for joining us. We are trying to catch up to our technology, and we'll be starting in just a moment. Well, it's getting to be 3:02, and we are still waiting on about half of our attendees. So if you'll all bear with us for one more minute, we'll see if we can pick up a few more. Thanks. Okay. All right, well, we at least have as many attendees as we have Kickstart Round 4. So again, welcome everybody. This is Melissa Moorhead. I'm a Program Manager for Data Across Sectors for Health in Michigan at the Michigan Public Health Institute. I should have met many of you in person last week. I'm very sorry I wasn't there. But we have had a couple getting started calls and looking forward to getting to know you all as a cohort. Thanks again, everyone. As we have been saying, we're really excited to get started with a new set of awardees and learn from you and with you about the different kinds of infrastructure and supports needed to promote an equitable culture of health across the nation. Next slide, please. We have an agenda for this call that has fairly tight timing. We'll give you a little bit of more welcome and background to DASH and All In. It's fair to say that's one of the most common questions we get in general, and especially from new awardees, is what exactly is DASH and the relationship between DASH and All In and the different institutes that make up the program office and technical assistance providers. We're going to hear a little bit about how DASH thinks about the universe, as we mentioned in the call for proposals and as well on our introductory calls. We can take it seriously to learn from the work that you're doing in order to help us improve as a national program office, but also help us to understand the field and help translate those learnings to the field at large and to the foundation when we get a chance to start thinking about funding priorities. The most exciting part of the event will be hearing from each of you in a lightning round of introductions. We do this to try to get you all a little bit more acquainted with each other, and then open up the possibility for you to make other connections with each other in the future. And then finally, we'll just talk about some of our next steps for the cohort moving forward. Because we get so many questions about what is DASH, what is All In, what's the relationship between the two, I'm going to hand this over to Molly. Next slide, please. As a newer staff member with DASH, who was at the meeting, hopefully many of you got to meet her. She has some firsthand insights and thoughts about how best to describe the relationship between all of our partners and our learning collaborative. Molly?
Hi, thanks, Melissa. Hello, everyone, and welcome. And, again, just congratulations. I know I'm very excited that you are here, and I hope that this is beneficial, edifying, and exciting for you as well. My name is Molly Malave. I am a program manager with the DASH team, and I enjoyed meeting many of you at the national meeting last week. So as Melissa previewed, I'm just going to do a little bit of level setting on DASH and All In. A lot of this is stuff you've heard before, so I'm going to move quickly, but a question that I got at the national meeting from, several people who were involved with DASH and some who weren't is kind of basically, so what is this again, specifically surrounding the relationship between All In, and DASH and you as part of a Kickstart cohort. Sometimes, we say that DASH is more than a funding program, so I'm going to try to take a moment to situate you in those structures and think about what that means. So real fundamentally, Data Across Sectors for Health, DASH is a national program office of the Robert Wood Johnson Foundation. The administration of the DASH National Program Office is shared between the Illinois Public Health Institute, where I am, and the Michigan Public Health Institute, where Melissa is, along with others on both sides. So the DASH National Program Office has developed and administered a few different funding programs over the past several years, with the ongoing programs right now being the DASH Kickstart program and the mentorship. You are in the 4th cohort of DASH Kickstart awardees. Please. And so All In, what is it? How does it fit? All In Data for Community Health is a learning collaborative online community and network of practitioners interested in multi-sector data sharing, which I'm sure you gathered at the national meeting, if nothing else. DASH is the original founder of All In, and basically, so recognizing a need to accelerate learning among early innovators in this field of multi-sector data sharing for health, DASH quickly joined forces with other national and regional programs to co-lead the network. So these are established partnerships, and all In partners coordinate technical assistance, disseminate promising practices in learning, facilitate peer-to-peer learning activities to tackle common challenges. So as you can see, it's a dynamic and continually evolving partnership, but these on the screen right now are the 6 who currently share leadership. If you were at the meeting, you'll remember Jessica from THNCI. That's just one of our partners. So next, please. I think basically the most important thing to know is that while DASH, the National Program Office, is a founder and a leader of All In, the network is much bigger than DASH alone. It's made up of practitioners, experts, and community members who engage in various online activities, including the online community, which you are probably familiar with, and the national meeting. So just to illustrate here, we had almost 400 attendees this year, and most were actually not awardees of DASH. So other awardees of other All In leadership organizational funding programs might be part of All In, and so are just a host of communities who really aren't directly affiliated with a funding program. This is all just to say that as a DASH awardee, you are part of All In, but it is bigger than just DASH cohorts, which I think is a great thing. There are lots of opportunities for connections there. So you, as a DASH grantee, Kickstarter, and a member of All In, you have a special place in my heart and in the All In network too. As a member of All In, you do get to benefit from the opportunity to connect with peers and experts, to share your work locally with the network and even nationally, and to learn from each other. But as a Kickstarter, I think you really help to shape All In and build a bigger movement for cross-sector data sharing work and collaboration that addresses social determinants of health and advances health equity. So you become part of the All In network, and your projects really generate learnings that become shareable knowledge for other communities who are getting started with this work. So when we say that DASH is more than a funding opportunity, I think this is really what we mean. Your experiences generate lessons that are really critical to the development of resources and opportunities in the All In network. You really are part of building a bigger movement, I think. And so this is just as a note why we might ask for documentation, and why when we do that, we really do encourage you to share what doesn't work in addition to what does. You're executing your projects. Roses and the thorns are really important to generating the learnings and kind of building up this network. And we'll talk more on that a little bit later. So this was really quick. Next slide. And we're going to go over just briefly, Melissa and I, just a few highlights of the most exciting opportunities with All In. You were all at the national meeting. You know, as you saw, it's a diverse crowd who shows up to work. I was, you know, impressed at 8 o'clock p.m. seeing y'all in the hallways, really digging in. It was exciting and really inspirational for me. And so, yeah, many different sectors, many different stages of collaborative work. And just I want to say, for those of you who were able to attend, I encourage you to reflect, send your feedback, and really look back and consider whether you would like to be with a collaboration, be connected with a collaboration you met, or really wanted to meet an attendee or a speaker or hear from anyone who is at the meeting, because part of the wonderful thing about the DASH program office and the All In leadership organizations is that we really can facilitate those connections in a lot of different ways. And so specifically, I think today it's really relevant to talk about peer-to-peer connections and how y'all as DASH cohort members might connect with each other, other communities on the line and past grantees. And Melissa's going to talk about that a little bit.
Do we want to ask for any reflections now? Anyone have an exciting takeaway?
I think at this point, in the interest of time, we can refer to the evaluation form.
Okay. Well, next slide, please. As Molly was saying, in addition to the national meeting, we also appreciate in-person meetups in a variety of different ways. And we have set aside money for awardees to both participate in conferences as attendees or presenters, but even more excitingly, have the ability to help facilitate peer-to-peer site visits. That's one of the reasons why we're doing the cohort call now, so you can learn a little bit more about each other. But also, since you had the chance, most of you had the chance to meet some other communities in All In, we do make that opportunity available between All In communities as well as just the DASH awardees. So there is a form that we have you fill out when you are thinking about doing a site visit, just asking you what you think that would look like and what you would want to learn. We can help make that introduction for you, or you can also be sort of planning it collaboratively with the site that you want to visit. Next slide, please. Because we can't always be in person, sadly enough, we are also promoting online connectivity. The SPLAT is what we have been calling it to date. Sometimes we say it's short for social platform. It's also sort of a nickname born out of the fact that we are co-creating it and building it as we go to try to be an online home that facilitates connections between people, both to continue the conversation that might have started in person, connect with new peers. We have been managing an events calendar. All In has some events, the webinars and meetings, that kind of thing. We also have posted events that we think will be of interest to the collaboration as a whole. And also we have a curated and tagged resource list. Now, one of the things we have just learned, so this is the first communication we're really trying out about it, but Health Doers, the group that had been in charge of creating and hosting the virtual collaboration platform, which is why it's allin.healthdoers.org, was a project of the National Regional Healthcare Improvement Initiative, ENRI. I'm sorry, I probably got that wrong. And they have decided that they are going to move out of that space. And so we will have to be moving the community to a new platform. Hopefully this will be a light lift for everybody and can only improve some of the connections that we want to make. But it's also a really important opportunity to be thinking about, and if you care, to provide some feedback about what features are most important to you or you think would be most useful when it comes to an online community. You'll be seeing some outreach from us. We also have always wanted to promote some user leadership on the platform. We can certainly create real ways for people to participate in designing and improving the online experience. So most of you, I think, have already major profiles. I've seen some people have found the Dash grantee group or the Kickstart group, and unfortunately for the duration of this project or the 6 months we have together, we probably won't be able to exploit those as much as we would like, just because we don't want you to have to do extra work to join back up once we have the platform ported to a new host. So that said, I'd like to turn it over to Claire to talk about our other part of our Kickstart grant, and that is learning from you. Claire, we're not hearing you, I'm afraid. Does still not hearing Claire. Okay, I'm still not hearing Claire. Hopefully we can get that taken care of. But I'll go ahead and start this section. Yeah, I think we're just looking that we're going to go ahead. So we think of our communities as having a certain core component. So when we do our call for proposals and think about what makes a good proposal or a good community for us, we are typically looking for those communities that have multi-sector partnerships in place, a good evidence of collaborative efforts around driving ways to drive community health improvement and equity, and of course that important data and information sharing component. So these are the things we're always sort of thinking about as our niche as Dash in the All-In network and in promoting this type of work generally. Next slide, please. So one of the things I mentioned earlier that we do try to do is build the evidence base for multi-sector partnerships that share data to drive equitable communities of health. And we do that for a number of reasons that you can see on this slide, and I did mention before. And then the way that we do it is, of course, through funding, and then through applying our framework and theory of change to literature, to our understanding of the field as a whole. And then in a more specific way, through survey, one instrument is called a national inventory, and another one is our own capacity assessment for community partnerships that helps us dig in and understand where people are in the field. Next slide, please. So our framework is an evolving document. You can see that we think about the reasons for data sharing. We talk about them as use cases. We do have some background in IT, so we get a little jargony there sometimes, but we have typically found that there are the broad buckets of multi-sector partnership and data sharing is to do whole person wraparound care. And then another big part is this place-based population or community health and wellness planning. So we use this framework to guide our data collection activities and also to structure the kinds of things that we ask from you and collect from the field in order to try to deepen understanding of these different domains. Next slide, please. And then as I mentioned, and as you've all been aware, we do field the capacity assessment that's more specific to elements of the initiatives, use cases themselves, which is kind of how we think about what you're trying to accomplish in the Kickstart contract, and get input from different participants in that work to see where people are in their understanding of what resources are available in the community to share data, what kind of trust exists between partners to actually, turn on that data sharing, and help assess whether there are commonalities and things that we can learn to help other communities move along faster. Next slide, please. Actually, if we can advance to slide 19, we'd like to move ahead into community introductions. And we'll come back to some of the awardee support that we will have for you to follow up on this. So that said, Anna, would you like to take it away, or Swati?
Great. Thanks, Melissa. I'm Anna Barnes, a Senior Program Manager with the Illinois Public Health Institute. So we are now going to dive into very short introductions from all of you to each other. So a little bit about the guidelines here. We went ahead and pre-populated slides with your project deliverables, the lead organization and partner organizations. We're asking each of you to just give a short 2 to 3 minute introduction to your project. And then just to keep us on time, since we do have a lot of communities that are in this cohort, we will have a nice gentle chime to kind of move us to the next community. So if you have questions for each other, we ask that you submit them in the chat box, and then we should have at least 15 minutes at the end of this set of presentations to ask each other some clarifying questions about the work that each of you will be doing. So with that, Swati's going to help us kind of MC between communities, and I think we have Alliance for Suburban Cook County up first. So Jeremy, Swati's going to unmute you, and you can take it away.
Jeremy, you are now unmuted, so you should be able to speak.
I can speak. Hi, everybody.
Oh.
Hello.
Yeah, we are the Alliance to End Homelessness in Suburban Cook County, and we are partnering with the Cook County Health and Hospital System, I believe now called Cook County Health. We are the lead agency for the Suburban Cook HMIS and are looking to create comprehensive data sharing workflow between the Alliance and Cook County Health for a flexible housing pool. So sharing seems to be a big item, so I'm excited to be in a community where other people have gone through that gauntlet and excited to learn from them.
Thank you, Jeremy. Thank you. And next we have Better Together Central Oregon. And Whitney, I am unmuting you right now, so you should be able to speak.
Awesome. So just a brief overview of our program. Better Together is a regional cross-sector collective impact organization that's focused on increasing positive outcomes from birth through career for young people. And for the last 2 years, we've been partnering with another regional backbone organization called TRACES, which stands for Trauma, Resiliency, and Adverse Childhood Experiences of Central Oregon, among other partners, to implement some regional measures around resilience that are really looking at, we're using these as population health measures really related to mental health in our community, and particularly for young people. So we'll be partnering with TRACES and a core group of partners to build a portal for our regional CBO partners to be able to access not just the resilience survey data, but also looking at key academic outcomes like attendance and early learning scores, et cetera, so that we can get a more holistic view of how to help young people succeed in our region. And I am interested in learning from others how we do data sharing across the distributed network and keep things connected towards shared outcomes and goals. So that is something that I'll be looking to learn from others in this cohort.
Thank you. Next we have Boston Medical Center Corporation, and
Renee, I'm going to unmute you as well as your colleague. Right, you both are unmuted.
Sujin.
Sujin, thank you. You should be able to speak.
Hi, can everyone hear me?
Yep.
Yes, hello.
Okay. Sujin, do you have audio access?
Yeah, can you hear me now?
Yes, perfect.
Okay.
So Sujin will do our brief presentation. Thank you.
Yeah. Hi, my name is Sujin. Our organization, Boston Medical Center Lighter Village, is a network of residents and organizations committed to maximizing child, family, and community well-being. And we have fostered partnerships between residents and organizations to improve the capacity of Boston communities to promote equity and child well-being. And we use trauma-informed lens to support collaboration across community-based early childhood health and education efforts. And then we support Breastfeeding Coalition, a network of men of color, and then community advocacy and leadership. And one aspect of our work is related to data, is that we have a publicly shared community data dashboard for Boston communities to just make useful information to Boston communities and families. So in part of that, our project is community housing data tool, and then we are hoping to make this tool to have a mobile-friendly web platform to share housing data and resources. So we have co-designed this housing data tool with community residents and then organizations to increase awareness about housing inequalities in Boston and support residents who are experiencing substandard living conditions, unaffordable and unstable housing situations. So we aim to improve our tool to include a mobile-friendly web platform to share housing and then health data, as well as advocacy resources, making the tool more user-friendly and accessible to families and residents in the Boston area. So we are working with multiple sector partners, such as Boston Public Health Commission, and then Children's Health Watch. And these are the deliverables that you're seeing in the slide. And then we are hoping to learn on how differently this collaboration across the different sectors in terms of data sharing will happen across the country. We are really looking forward to learn from everyone. Thank you. Renee, is there anything?
Next, thank you, Sujin. Next, we have Camden Coalition of Healthcare Providers with Aaron. You will be unmuted, or you should be unmuted right now.
Great. Can you hear me now?
Yep.
Hey, everyone. This is Aaron Truschel over at the Camden Coalition of Healthcare Providers. We're a multidisciplinary nonprofit that works to improve the care of complex populations. So we work with all of the health and social service providers throughout our community to do some direct service work and a variety of convening and collaborative work. And so the reason for this Kickstart grant was that we have been one of 30 communities that's in the midst of implementing CMS's Accountable Health Communities effort, which involves the screening of social determinants in clinical delivery settings and building out a really rich data set around the social determinants of health in our region. And so over the past year and a half, we've been implementing AMP-ERSA across a wide variety of settings, from hospitals and emergency rooms to primary care practices and other clinical sites, where they are starting to screen large swaths of the population using the CMS Accountable Health Community Screener. We've separately, for a good number of years preceding that, have been running a regional health information exchange that's pulling in real-time clinical data from many of the healthcare institutions in our region. And so the goal for our Kickstart grant is to start to plan out the integration of these two systems And really, I mean, it comes down to how do we start to share social risk factors in the clinical setting. So there's a couple key pieces that we're hoping to learn, and one part of that is around person linkage. So how do we take these self-screeners and link that data back to the HIE? It's, you know, a slightly different data source than we're accustomed to. And so there's some sort of feasibility testing around how do we do the person linkage, but that's more of the sort of getting the pieces in place to do the more sort of interesting, innovative stuff, which on our end sort of fits into two buckets. One of them is how do we start to, you know, as I said, share those social risk factors both in aggregate reports so that a primary care practice can start to see, you know, what is the intersection of clinical risk factors with social risk factors for their given population, but also down to the individual level. So how do they, you know, when they're working with a patient, you know, and, you know, when they're in front of a provider, how does social risk start to get exposed into that? So that's one piece of it. The other part of it is around how do we potentially use natural language processing to tap into all the rich text data that lives in our health information exchange. So, you know, we're screening in the realm of tens of thousands of people through the Accountable Health Communities grant. We have many hundreds of thousands of people in the HIE, and we know that those social risk factor data isn't being exposed in any kind of, isn't being captured, I'm sorry, in any kind of structured format. And so we want to use the Accountable Health Communities data as a training data set that we can start to see if there's the potential to scrape more social risk data out on the broader population. So our goals and, you know, what we hope to learn from others are, you know, how have others been tackling, if they are in the space of, you know, showing social risk in the clinical setting, you know, what kind of lessons have they learned? And if anyone has experience with natural language processing, any of the, you know, pitfalls that we could avoid there.
Thank you, Aaron. Next, we have Crisis Response Network. And Tyler, I will be unmuting you in just a few seconds. You should be able to speak now.
Perfect. Hi, everybody. My name is Ty Rosensteel. I'm out in Arizona. Shout out to the Suburban Cook County friends in Chicago. We are former colleagues. So hi, everybody. We are doing a project in coordination with a couple of healthcare plans here in Arizona. We manage the homeless management information system and have data on approximately 15,000 people that are experiencing homelessness on a given night in Arizona, and are looking to do data matching with a couple individual healthcare plans that have integrated services for people that are experiencing homelessness. And the idea behind this data matching is what data can we get from the healthcare plans that can be meaningful in prioritizing housing for persons that are really vulnerable. And additionally, what data could be shared that is of value to the healthcare plans from the homeless system in terms of helping them connect with and identify persons that they are targeting for particular treatments or for helping to manage high-cost, high-utilizers. The goal of this is to be able to demonstrate the value for an ask to our state Medicaid system and do this across all of our HMIS systems and all of our healthcare plans. So right now we're doing this on kind of a micro coordination level and have data share agreements to do kind of exchanges on a client by client basis. We're looking to expand this out in this particular grant to demonstrate the value of doing that on a more regional approach and hopefully take that to the state and really have information that can fund or inform future projects like HIE integration. In terms of what I hope to learn from others, I really hope to learn about the process of influencing policy. So making sure that items are taken from individual projects to something that's really sustainable, that can be taken on a large scale rather than remaining as a single one-time project. Thank you.
Thank you, Tyler. Next, we have Data Haven with Mark. You should be unmuted right about now.
I got it.
Go ahead.
I see the little flashing sign. Hi, this is Mark. I'm the director at Data Haven. Josephine from our team is on the call. And we are a small nonprofit. We focus on data collection and sharing. And one of our projects is working on the community health needs assessments for all the cities around Connecticut. It's about 100 different cities and towns. And that community health needs assessment, as many of you know, it's used in advocacy and communications locally with the public partners and nonprofits. So our project focuses on addressing the language barriers in this work in advocacy and communications, sort of looking at upstream and downstream approaches to language access. So that would involve translating materials and assessments into different languages. Hopefully the language access could be relevant, you know, both within Connecticut, but also nationally. And then using that work in other work in resident engagement as well. So we have some work around media and resident engagement and video storytelling. So hopefully providing some of those services and, you know, making sure that residents could participate in those activities regardless of their native language. And then our goal is to, you know, explore the boundaries of, you know, language access and community engagement sort of beyond the traditional outlets that we have seen in the past.
Cool. Thank you, Mark. Next, we have Blue Hills Community Health Alliance with Kim Williams and Ashley Stockwell. I'll be unmuting you guys in just a few seconds. Ashley, you should be unmuted.
Great. Thank you so much. And I apologize in advance. I'm at a conference, so it's quite loud in the background. So I'll make it quick. So my name is Ashley Stockwell. I work for the Blue Hills Community Health Alliance, which covers, it's a regional public health coalition that covers 13 communities just south of Boston. And we have recently started a project around community transportation and really understanding what transportation issues exist for our residents and then addressing those through a 4-phase project, which includes a needs assessment, regional action plan, implementing pilot programs, and then expanding those programs to all of our communities. So some of our deliverables include the needs assessment report and then how to share that, as well as how to share the inventory of existing transportation services that we find, and then basically more thinking about how to share that beyond just presenting the information, but really having a tool that allows agency leaders to better connect their clients with transportation services. We hope to do that through some data visualization prototype. I apologize. One of the other things we're hoping to do as well is implement social determinants of health screening tools that allows our agencies to collect transportation data, since most of them are not doing that as of yet. And what we hope to learn from others, we really just want to learn about best practices around data sharing. We have little data experience, and so we're very much looking forward to learning from all of you. Thank you.
Thank you, Ashley. We are going to take a pause, and I'm going to keep going. Apologies. Next, we have health leads, but Lauren will not be able to present, so I'm going to have Susan, who's another member here on DASH, to present on her behalf.
Hi everyone, this is Susan. I might have spoken to some of you throughout the conference or through some calls. So Health Leads is really part of the Bay Area Learning Initiative, which consolidates about 45 to 54 different organizations throughout the Bay Area, all focusing on doing a housing assessment and the lead partners. So while the lead organization is Health Leads in Boston, they do have a chapter out in the West Coast. And so some of their partner organizations include Contra Costa Health Services, the San Francisco Department of Public Health, and the Community Health Center Network. Some of the deliverables that they'll be sharing with us include a measure library, which would include their recommended measures based on the community engagement process, including data sources, descriptions, and calculations that they've come up, as well as a prototype report, which will demonstrate the visualization of their data and be used as a springboard to understand the data collection systems necessary for their work. And finally, to build an infrastructure to undergrid their reporting and data collection among their members.
Thank you, Susan. Next, we have Ann Robert H. Lurie Children's Hospital of Chicago with Michelle Macy. Michelle, you should be able to see. Michelle, are you? I don't see. Oh, I see. There you are. You should be able to speak now.
Can you hear me now?
There we go. We can hear you.
Terrific. So I'm Michelle Macy from the Ann and Robert H. Lurie Children's Hospital of Chicago, and we are partnering with the Chicago Park District and Chicago Public Schools, as well as a number of other organizations that are focused on water safety, swim lessons, and drowning prevention in the city of Chicago, to work on the establishment of a drowning surveillance system that will include information from water-related incidents in the Lake Michigan waterfront, the river, as well as the pools that are in our community, and then the environmental conditions that are going on, the lifeguard staffing hours, and we're also going to be looking at the swim lesson, learn to swim programming that's available throughout the city, and try to begin to piece together where we have opportunities to increase water safety awareness in communities and decrease the incidents that we have of fatal and non-fatal drownings.
Thank you, Michelle. Thank you, Michelle. Next, we have Metro United Way with Kenny Brown. Kenny, you should be on.
Yes, hi, this is Kenny in Louisville, Kentucky, representing Metro United Way. And we are partnering with a technology vendor, Unite Us, Jefferson County Public Schools, which is the largest school district in Kentucky. They have over 100,000 students in 150 schools. And Evolve 502, which is a partnership of government, education, and nonprofit, which is designed to increase retention rates, increase graduation rates for students, and entry into the workforce. What we are doing is integrating a referral platform with JCPS School District's Bright Bite system, which predicts or measures absenteeism and other determinants of whether students are falling off track. Also with the state system, which is called Infinite Campus, which is used to measure student success in school. What we are hoping to do by integrating all three systems is to identify students who are falling off track using JCPS's current systems and refer them to agencies that can address social determinants of health through the Unite Us platform. What we hope to do is that by addressing the social determinants of health that lead to root causes for students, such as food insecurity, which prevents them from being able to study in school, or lack of transportation, which prevents them from getting to school on time, that by addressing those issues in a collaborative way, that we will see retention and school rates go up. So our deliverables will be to present a lessons learned document. JCPS will be the first K through 12 system in the country to be on a platform like this. And so we'll be presenting some information such as, you know, how did we get through a data sharing agreement with JCPS? What were the technology issues that we had to address? And we also are working to facilitate some change management to allow the school district to be able to work differently to address our students' needs. I think I talked a little bit about our project goal, but ultimately not within the 6 months, but hopefully at our first year and second year cohorts as we follow students through the system. We hope that we will see improved graduation rates, increased scores in school, and also a decrease in absenteeism and latenesses.
Thank you, Kenny. Next we have the Minneapolis Public Housing Authority, and McGean and Kelly and Lucia. I'm going to mute all of you right now. All should be able to speak as I'm unmuted.
Thank you so much. This is Megan Keynes from the Minneapolis Health Department, and I'll go for our group here. Our partnership brings together the Minneapolis Public Housing Authority, the Minneapolis High-Rise Representative Council, and the Minneapolis Health Department. Hennepin Healthcare is also in the mix there. It's really the three primaries are the Housing Authority, the Representative Council, and the Health Department. And our notion is that we want to build on the relationships that we've learned while kind of living through the process of understanding what an authentic relationship looks and feels like in this work. And what we mean by this work is the commitment that the Public Housing Authority and the High-Rise Representative Council have to creating a health strategy to improve the well-being of the residents extends to needing to take that centered lived experience information and really support it with some data. And so our goal is to leverage existing data and resources to create something that is attractive and usable and centered on the residents. So we've been calling it a dashboard as a way to describe what we're doing. We feel like the real thing here that we want to accomplish, though, is something that is really engaging the community in how to design and use this thing. We say it a lot, and we want to make sure that we are moving through this space together. So we've got some tricks and techniques, like we're going to use a graphic facilitator to help us have some of these conversations and make sure that the community is really with it and centered it and driving it. And so we always want to vacuum up other tricks and techniques that others have. But, you know, from my public health place, there's nothing certain except for constant change, and it can't be static. So we're looking to get to develop some more of those relationships so that as all of us move through this work together and adjust to the next new thing, we've got that sense of community to support that work and help us to be both authentic locally and challenging our colleagues to do the same.
Thank you, McGean. Next, we have University of Missouri St. Louis with Paul. Paul, you should be able to speak now.
Perfect. Hey, everyone. I'm here at the University of Missouri St. Louis and run an initiative called the St. Louis Regional Data Alliance. And for the purposes of this call, I'm just going to focus on some work we are doing to provide some technology infrastructure and recommendations to our local United Way 211 as it makes a transition to become the sort of central hub for a community information exchange, a regional community information exchange in St. Louis. And so as we were thinking about this work and thinking about what that meant, or the implications of transitioning from just an information and referral platform to something that was providing closed loop referrals, collecting and protecting client information, what we realized is that there were a number of data components that we were essentially creating standards for how folks throughout this network, what we anticipate will be hundreds of nonprofits, will use to collect data. That includes demographic information, a social determinants of health assessment. Fortunately, the open referral human service data specification is sort of already taking care of the information and referral piece. And we also needed to connect the dots with some sort of umbrella taxonomy that was a little bit more open, but also connected to existing taxonomies like AIRS and NTEE. So essentially, there's a lot of work to do there. What we wanted to do was sort of draft and workshop a series of open standards for the demographic piece that's aligned with the census and HMIS, for the social determinants of health piece that's aligned with national best practices. And we had a number of great models that we were exposed to at the conference last week, workshop them with community partners, and then begin to sort of document and publish them in a way that everyone in St. Louis can use to begin to align data systems, but also hope that folks throughout the country that are developing similar systems can also use, learn from, adapt, et cetera. So we're excited to dive in and excited to learn. And the one final thing I will add, which was also something that really kind of rang loud and clear at the conference last week, is also wanting to include and deeply embed a focus on data privacy and data consent, sort of taking off of some of what Dr. Boyd was talking about and automating inequality, and making sure that that's integrated throughout.
Thank you, Paul. Next, we have United Way of Southampton Roads with Mary Miller. Mary, you should be able to speak now. Mary, I have unmuted you, so I'm not sure why we're not hearing you. Mary, are you able to speak? Okay, Mary, we will come back to you. We're going to move on to the Western North Carolina Health Network. And Joe, I'm going to unmute you in just a few seconds. Joe, you should be able to speak now.
Yeah, hi, I'm Joe Bradley, and I'm with WNC Health Network, which is an alliance of the hospitals working together with partners to improve health and healthcare in our region. So our region covers the 16 counties in the 16 westernmost counties in North Carolina. Our partner organizations are really from WNC Health Network. One of our programs is WNC Healthy Impact, which is a partnership and coordinated process between hospitals, public health agencies, and key regional partners in WNC. UNCA is one of those other partners, key regional partners. And we work together locally and regionally to assess needs, develop collaborative plans, take action, and evaluate progress and impact. One of the ways we do that is through standardizing and conducting data collection. So for the past 3 CHA or CHNA cycles, we have collected a primary data regional survey, a random survey, and part of this project is to explore our entire data set. So we've been able to look at the data kind of individually from year to year, but we haven't been able to really combine the raw data and analyze it on a deeper level using an epidemiologist. So these Kickstart funds are really going to help support us exploring that data with the idea that we're really trying to dig into equity, the disparities in our region, and look at how that affects race and ethnicity, different socioeconomic groups, gender, different things like that. So we're really excited to be able to use the funds to kind of dig deep and explore our data on a different level than we have before. The second deliverable that we have are data stories. So we currently on our website, if you guys want to go check them out, we have them live right now at wnchn.org, but we have data stories for our 10 or 11 key health issues. And these data stories have kind of important county data. They've got story behind the data from key informant surveys across the region, what's happening in the region, how it's being prioritized. Lots of stuff for our community members. And the idea here is to use the finds from our equity data exploration of our primary survey data to improve these stories and include kind of a new equity lens. We also, as part of this project, want to collaborate with community members with lived experience to gather feedback and really make these stories deeper and more meaningful for our community members. So I hope that kind of covered everything. Our project goal, what we want to learn from others, we're really interested in how to connect with these grassroots organizations that we don't typically connect with, because we're usually kind of at a regional level with our partnerships, and gathering feedback from these community members and attempting to, do no harm as we highlight disparities and inequities in the region. So that's it.
Fantastic. Thank you, Jill. We will go back to Mary since she was able to call back in. Mary, you should be able to speak in just a few seconds. Try now. You're unmuted.
All right, can you all hear me now?
Yes.
Okay, yay, good, thank you. Okay, hi, my name is Mary Miller. I work for the United Way of Southampton Roads over in Virginia, and our project is GHR Connects, which is our regional population health dashboard and resource. So it was originally designed back in 2016 by local leaders from a variety of fields, including healthcare, education, the economy, and we've supported a variety of partners since its inception, but a lot at the population, primarily for population health. So when our hospitals and public health departments make their community health needs assessments or improvement plans, they've used our dashboard, which has been a big success in our region. But working for United Way, we also make a lot of community investments to community-based organizations. And so the project for DASH is to integrate some of those CBO outcomes into our population health dashboard and align them up to with some of the CHIP outcomes. So with DASH, we'll be uploading those outcomes from about 37 CBOs. For example, we fund a lot of early childhood development initiatives, including programs that administer early childhood screenings like the ASQ. Multiple partner agencies have committed to like a system of shared measures in ASQ. So maybe the % of children receiving screenings or information about referral outcomes as results of screenings. And so those are going to roll up on our dashboard to kind of combine with local public health departments and hospitals who have goals for improved early childhood outcomes. Locally, our goal is primarily to increase some capacity with our CBOs. We want them to be able to confidently bring their work and their data to the table when we have these conversations with healthcare and public health partners, because they're doing a lot of great work on the ground, and sometimes that can be disconnected from the CHIPs or the CHINAs that are going on. And so hopefully that'll improve all of our ability to kind of take action on these shared goals. I'm super excited to hear all of your projects, because we also use Unite Us here at our United Way for a variety of projects. And we're just interested in measuring different things like trauma, I think I mentioned in the chat, to see how we're tracking things, how we're working with partners. It sounds great. Sorry, I also talk very fast.
No, you're good. Thank you, Mary, and everybody else. We're so excited to have you a part of this cohort. So congratulations on sharing everything about you all. So thank you.
Yay!
All right, we are going to move on to the Q&A.
Great. So a bunch of questions came in. A couple of them I'm going to try to ask, but Swati is going to also help me see if we can unmute some of you. So the first question is from Tyler from Crisis Response, a question for Jeremy. What is the flexible housing pool? Can you just give us a super quick summary of what that initiative entails?
Jeremy, you should be able to speak now, and Tyler, I'm also going to unmute you in case you have any other follow-up questions.
Hey, Tyler, shout out to Arizona. The flexible housing pool is money that's been set aside through, I believe, through a healthcare initiative here for housing. that Cook County Health has put together. Right now, Chicago's already participating in it. For those of you on the call that don't know, the Alliance to End Homelessness in suburban Cook County, Chicago and the surrounding suburbs are all in one county, and essentially Chicago has its own HMIS and its own system, and we are the suburbs that surround the rest of that in the same county. So, so yeah, we're just looking to catch up and get involved with that housing pool that's there, so more integration can happen with homeless services and the healthcare system to get people housed, or who are at risk at housing, keep them at risk of homelessness, keeping them housed.
Great.
That's great. Thank you.
And Tyler, since you're unmuted, if you would just go ahead and ask your question about community referral platforms. I think it was for one of the Metro United Way in Louisville, about Unite.
Yeah, so the piece, so we're, our state Medicaid office and a couple of our state departments are interested in leveraging community-based platforms, and they're in the unfortunate situation of trying to choose a vendor before trying to really identify what their underlying need is. So I'm really trying to push at them to say, what is the need that you're trying to fix, and what is the problem that you're trying to solve before trying to just purchase the software platform. So if you were willing to share kind of what was the specific need that Unitas was meeting. The other thing that I just thought was interesting, I'd never really considered a software vendor as a partner in a project like this. So I was just sort of interested in why you identified Unitas as a partner. You know, I would have just thought of them as a, you know, they're my software vendor. I wouldn't necessarily list them as a key collaborator. And I just wondered if there was something unique that they were kind of adding to the partnership in your particular project.
Sure, this is Kenny. So I'll start with the second question first. They are definitely our technology vendor, but the reason why we call them a partner is because they've been extremely collaborative with us in helping us to address some of the challenges that we wouldn't have been able to necessarily address with other vendors. For example, we have several grants that we are using United Community to track progress with. They've built custom forms for us at no charge. They've done custom workflows for us. Specifically where it relates to the school system, they are working at making connections that have not been made by them before, and are working very seamlessly with the JCPS school system to help them try to create a process that will work for them. Some of this includes like single sign-on, which is not something that they would traditionally do with their integrations. They're connecting with 2 other systems that are not Ruby on Rails systems. That is what they generally have APIs for. So we are considering that they're doing and going above and beyond what is part of our contract with them to make this process work. So that's why we consider them both a vendor and a partner. Your second question about, or I guess your first question, which I answered second, which I'm answering second, is about Medicaid. And how our process is a little bit different from Medicaid. So at the same time that we are launching United Community in our 7 counties, because Metro United Way only runs in 7 counties, the state is running or has a Medicaid contract out. The state is also developing a system with Deloitte that is very similar, but they have not launched yet. And so our goal we project that we will be launched and penetrated within our 7 counties before the state system gets off board, and they will likely probably connect with us instead of competing with us. The reason why the state system and the state is wanting to do something like this in our effort is a little bit different than why we engage with United Community. So we engaged with Unitas to launch United Community really to address social determinants of health for all of our citizens. And we know that generally speaking, when you connect or when you address more than one need, that people have better outcomes. The state has a little bit of a different motivation under the Medicaid grant, and this is my personal opinion, having worked for the state previously here. Our Medicaid grant does offer some incentives to the healthcare organizations that if they are able to reduce hospital admissions and other things by addressing social determinants of health, there are some bonuses for them in their contracts. And so in order to put that in the contract, they also have to give them a vehicle by which to do that. I hope that answers your question.
Yeah, that's so helpful. Thank you so much.
You're very welcome.
Great, thank you guys. I'm excited to see that there are some connections here. So we have a question from Mary. I think Mary's with United Way Southampton Roads for Whitney and Better Together in Oregon. So Whitney, she's interested in learning how you'll be tracking ACEs and resiliency data at the population level. They play a role in trauma-informed care, but they're having a hard time finding population level measures.
Mm-hmm. Am I unmuted?
Yes, we can hear you.
Okay. So that's a really great question. In our work, we are actually not interested and not focused on the ACEs aspect as much. That mainly from our approach and kind of our use of data. So we're not going to change trauma that kids have experienced. What we really want to focus on is creating cultures and schools and after-school programs and community-based organizations and health centers that are responsive to kids and families' needs and are focused on really building the resilience aspect. We define resilience as positive adaptation in the face of adversity. So it's that hasn't necessarily been the critical piece of our work. I also there's some regional work that's happening, I guess statewide work that's happening in Oregon around understanding social complexity, so kind of where health complexity and social complexity match up. And there's been some work done with our Medicaid patients or Medicaid members to understand kind of the prevalence of social and medical complexity together. But at this moment, that is not data that we, that individual level data that we are planning to bring in just because of its kind of sensitive and new nature. But our resilience work is really focused on measuring the positive resources that kids have access to, that community members have access to help them navigate ongoing stress, toxic stress challenges, adversity, trauma, et cetera.
That's super helpful. Thank you.
Mm-hmm.
Even so, without just including the ACEs part, I'm definitely excited to hear what you all end up measuring because, well, we kind of serve as backbone to a local trauma-informed care network right now, and so I know they're always interested in where to move forward. So that'll be great.
Yeah, if you want to connect with me offline, I'm happy to share the tools that we're using. We do have some validated measures that we are using.
Awesome. Thank you.
Yeah.
Great. And then I think this was from Mary to Paul at University of Missouri St. Louis. And I think for anyone else on the call or for those of you that were at the national meeting, is anyone else looking into open referral? There was quite a lively conversation with Greg Bloom at the national meeting. So Paul, if you want to take that first, and then I guess if anyone else wants to chime in, just you can raise your hand in the chat or just chat into the box and we'll make sure we can unmute you.
Yeah, so a lot of lively conversations, and Greg is certainly good at starting them, whether or not people want to engage. So I've appreciated that. And what was interesting about open referral and the human service data specification for sort of the 211 piece or the information and referral platform piece is that it seems like at this point, most software platforms, maybe absent Aunt Bertha, have adopted the human service data specification as their like interoperable data standard. So when they are sharing data, you know, within other systems, there is now this sort of common translation key. And we think this is really exciting. It's been really cool. I've been following, you know, Greg's work and Open Referral's work for years. And it seems like with the adoption of the specification by WellSky and by Healthify and by a number of others, folks are sort of recognizing that people are always going to need to share data with each other, and that, you know, doing these sort of time-intensive one-to-one connections from data system to data system is not in anybody's interest. And so, you know, one of the things we're interested in or sort of concerned about is when you broaden the conversation from a 2-on-1 or just an information and referral system to a community information exchange, there are a variety of other data elements that have not had that level of scrutiny and sort of a deeper dive into what does interoperability look like, and how do we make sure that we're not committing some of the same mistakes as sort of early EHRs, or really a lot of software platforms that are developed for nonprofits that make it really hard to sort of migrate data or to share it with other systems. So I hope that answers the question. I think that, you know, a lot of the open referral pieces help existing software talk to each other. I think the challenge now is with these newer systems like Unite Us or Now POW, et cetera, that are coming into the fray. What are the other data components that need to be similarly open, connected, et cetera?
Thanks, Paul. Mary, I don't know if you had any comments you wanted to add to that, or if anybody else wants to chime in on this particular piece.
No, that's great. I just find it fascinating, so I'm excited to hear how you all go about it.
Great. I think we have time for maybe one more question if anybody wants to jump in that hasn't had a chance to share yet. Great. Well, thanks everyone for being really on top of time management and for asking some great questions to kind of tee up some future dialogue among these sites. And we learned a few things that we didn't know about some of these projects, so that was great. I am going to just walk us through a little bit to sort of tie us back to the beginning of the conversation where Molly talked about the relationship between DASH and All In. As you know from the pre-award calls, we will be doing monthly check-in calls, and all of you have been assigned a primary and secondary liaison. Previously with Kickstart, we were doing monthly calls, so this will be a little bit of a change for us, which hopefully will work in everyone's favor. In between those monthly check-in calls, we'll have a really short form for you to submit some written updates. And then at the end of the project, we have a final narrative and financial report. I'm going to share on the next slide just some of the components of the final narrative report so that everyone doesn't feel much anxiety about that. It's pretty straightforward. So to clarify, bi-monthly check-in calls, they'll be taking place every other month. And I think most of you are in the calendar for some time at the end of this month or early November. So in terms of additional support that we'll be providing where really where DASH grantees kind of have the luxury of taking advantage of the All-In network. This conversation and then your attendance at the national meeting are sort of our first two forays into identifying where there's commonalities and who you want to connect with. So at the end of this webinar, you'll be submitting a form and just let us know who you'd like us to help facilitate some one-on-one connections with. Or if you already have an idea about someone you'd really like to visit in person, let us know. If there's interest, we're happy to convene you again, maybe towards the end of the 6 months to hear sort of success stories and lessons learned. So the next slide then, so this is some of the final report questions that we'll be asking you. We do customize everyone's template so that we can make sure to unpack specific questions that we teed up that we really want to learn from your project specifically. For example, in this cohort, we have a handful of communities looking at education data, which is something that we haven't had a lot of examples of within All In before. So next slide. Secondly, we are here to really help you, figure out the pieces of your project that are of interest to the larger network. And I'm sure you got a good flavor for that at the national meeting. But as you're winding down your project, or even as you're in the middle of it, we'd love to schedule you for all-in showcase webinars, or feature your project as a case study or a bright spot in a publication. And Peter does a monthly, or even more frequently, he does a podcast. And really the bread and butter of that is showcasing the community collaborations that are a part of the network. So we'd love to do interviews with you for that as well. And then next slide. Just want to talk about how we've continued to try to improve how we support Kickstart awardees in documenting the lessons that you're sharing with us through the calls and through the reports. Will help inform the pieces of your project that are, most interesting to the larger network. And the way that we support you in that is to produce some deliverable or product or summary recommendations that can then you can take around locally to shop around to local partners and funders, but that we can also publish in the All-In Network. So these are just two examples. Both of these communities were present at the national meeting, so you may have connected with them. But we're here to help be a sounding board to the content that you write, but also we can provide a little bit of support in terms of layout and graphic design to make it publishable. So next slide. Great. So let's pause here and see if there are any questions just in general about the program expectations or the peer-to-peer connections before we wrap up. Great. Okay, thanks. So one point of clarification here around the connections that we facilitate. We don't want you to feel limited to requesting connections just within the cohort, but if there's a particular topic broadly that you need technical assistance, or you want to talk to other communities about, whether it's a particular data type like HMIS data or a particular vendor that other communities are engaging, let us know that as well, and we can put that in the online community or help make connections in that way. So don't feel limited by this group per se. So just to close out, we have a very short evaluation form that we'll be putting in the chat box and emailing out. And then we do publish a lot of information in our All-In newsletter, so all of you will be added to that. Definitely let us know if your partners would like to be subscribed to that as well. And we welcome your partners on our check-in calls. It really helps enrich our understanding of the different roles that the partners play. In terms of the capacity assessment, we will be sending you an email requesting the contact information for your lead partners and collaborators. Each of them will receive a link to complete the survey in the next couple of weeks. So guidance is forthcoming on that. So yeah, that's all we have for you today. We just really wanted to take an opportunity to get you all together on the phone. And we realized as we were planning for this that we forgot a lot of you would be at the national meeting. So hopefully that was a really helpful opportunity to jumpstart some of these conversations. Any final questions or thoughts? Great, and we will be, we do have a recording of this that we can send you that if someone from your team would like to listen and wasn't able to attend. And then Adrienne has a question here. Access to summaries of the awardees. That's a great question. We have in the past worked on creating like project profiles. We might be able to put together a very simple like template and you guys could populate it, and then you could kind of have a short one-page description of each project. I think that if that would help kind of document these projects and opportunities for connections, we can certainly work on something that's a low lift. Great. Thanks, Adrian. Perfect. Well, thank you so much. We look forward to talking with all of you next month in our check-in calls. So take care.
Thanks, everyone. Bye-bye.
Bye-bye. Bye-bye.